Thank you. So kind of you. Well, I try and establish each year some theme, some message that SIF can be instrumental to each of us, a theme that we can take home and something that should be extremely important. And we've been working on something for the past several years, sometimes swimming upstream, this whole question of radiation safety. And this year, Mark Herms and I said, this is going to be the year that we pound this message in, because we want to go forward from this meeting and hand this off to Sky leadership and work with Sky leadership to make this the #1 priority in interventional cardiology. All right, so let me start here. Who played the first college football game? Anybody? John. Rutgers and Princeton. November 6th, 1869. There were 100 spectators. Rutgers won 6-4 based on the old rules. They were old European rules. It wouldn't be until 7 years later that representatives from the Ivy League came and started to develop the modern football rules. And I would submit to you that since 1869, things in college football have changed just a little bit. This is a game that Sam Conaway and I went to a few years ago with 115,000 fans. Just a little bit of change. And over the last 4 decades, and especially over the last 10 years, there have been equipment enhancements to promote safety and reduce injury to college athletes. Very necessary. However, in the most advanced field of medical science over that same time frame, little has changed in the lab to reduce occupational health hazards. Well, our little spokesperson model here, she's very happy with her lead. It's brightly colored, autumn colors or whatever, but no protection, arms unprotected, legs unprotected. Little has changed to protect doctors, nurses, and technicians. And we doctors go in and do a couple of cases. The nurses and technicians are in there for a dozen cases each day. And you cannot separate this issue of radiation exposure to the overall question of what happens in terms of other occupational health hazards. For instance, the burdensome lead causing orthopedic injury. We had a group last night that met and discussed this, and every member of the group, over 40, has some sort of orthopedic long-term malady. So we know that radiation exposure and its long-term deleterious consequences affect more than physicians. It's everyone in the room, and whatever change we make has to benefit everybody in the room, not just the primary operator. So it's sort of a cascade. We get X-ray imaging, radiation exposure, not good, and we try to employ radiation protection, but the lead apron is less than a pure cure. It incompletely addresses one process while creating several new disease processes centered around orthopedic injury. I recently visited Spencer King, and he had this to say. We're shooting a documentary on this, and he said the volume of cases per operator, cases per lab, and therefore what he calls apron time, the complexity of the cases, structural and CTOs, you see how long CTOs took this morning, more images, more radiation, longer lead time, and more exposure and deleterious consequences to the operators, nurses, etc. And when you start to talk about this, some of the things are intuitive. Cataracts, over half of mid-career individuals already have cataracts, left-sided brain tumors, breast cancer, spontaneous abortion and miscarriage, skin cancers, not to mention leukemia, lymphoma, and multiple myeloma. Now, I'm not trying to paint an ugly picture. What I'm trying to set forth is the need for us to change this exposure, to change our how exposed we are in the lab. Does anybody know what this is? We've been taking radiation exposure very lightly for 100 years. Anybody? This is what's called a shoe-fitting fluoroscope. And shoe stores around the country had this. And this was state-of-the-art. You brought your kids, they tried on 10 pairs of shoes, and you put them under the fluoroscope. And you look to see how the shoes fit. And Dr. Scholl's was all over this. Salesmen were getting up to 100 millirems a week 100 years ago, just to see, did the shoe fit? And then there were unintended and unforeseen consequences. So we've been taking radiation in the workplace and the exposure to radiation. I mean, think of all the little kids who went in there and couldn't make up their mind on their PF flyers. So the Brannock device, while crude, was really thoughtful. By the numbers, this is dated a little bit. This is from 5 years ago. 8,500 interventionalists in the country. A little over 6,000 in 2018 submitted Medicare claims. And another, 5,000 vascular interventionists, EP docs, and 25,000 nurses and techs in the lab. All of them really ignoring the idea of what the radiation exposure is, or at least not thinking of it in the terms that is, in my mind, perfectly responsible. Exposure data. Interventional cardiologist, this is what he or she gets over the course of a career on average, equates to the chest between 2 and 10,000 chest x-rays. The brain is most unexposed. Imagine this, 25 to 50,000 chest x-rays in a career. If I asked you to put your face or your head under an x-ray tube and shoot it off 25,000 times, you'd think I was insane. Complex PCI, complex structural, accounts for more of the cases we're doing. Radial access. I love radial access, but trying to protect the operator and the secondary operators in the room is more difficult, potentially, with radial access based on this data. I had to go back and learn where the radiation was coming from when Jim Goldstein turned me on to this topic 4 or 5 years ago. He started off by saying, how do you feel at the end of the day in the cath lab? And I thought he was looking for something high-end. I said, oh, exhilarated, I love it. He goes, no, how do you feel physically? And I said, well, my back hurts a lot, and I go to physical therapy all the time. The primary source is the image intensifier, but the main source is scatter from the patient. And what I really needed to learn, look where the hot zone is. The hot zone is the waist, and this might explain the risk of miscarriage that cath lab nurses and cath lab physicians that work in the cath lab who are female experience. For every 600 physicians in residency or fellowship, about 6 will, who are in fluoroscopic-based subspecialties, 6 will develop cancer over their lifetime, potentially due to radiation, and the absolute increased risk of cancer, we believe, is 4 to 5%. I won't go into deterministic, but in stochastic injury, something you should know. Cataracts. In this study, over half the individuals working in a cath lab already had cataracts. In this ACC survey, ortho issues in half the cath lab workers. It gets worse when you go to work in the morning, and half said, I got to get out of this. Brain tumors. What's the connection? We're not sure, but we do need studies to establish this potential link, especially most of the time, 85% of the cases of cath lab workers are left-sided brain tumors. This was a man that I dearly loved working with, Ted Dietrich. He died of a left-sided brain tumor. But rather than me tell you his story, I'd like him to tell you his story.
All right, let's have you.
I drove into the garage and I put my hand up on my button and the garage door came down. And then I reached over with my hand to open the door, and I couldn't find the door handle. I lost complete control of my hand. By the time I arrived at the emergency clinic at Barrows, I was in a full-blown seizure. So then they put me in the MRI, and the next thing I remember, I wake up. The surgeon comes in, a young guy. He says, well, you've got a brain tumor. We have to take it out, and then we can decide how we treat it.
What we see here are your post-op study. We see a small cavity there with a tiny nodule of enhancement along the anterior lateral margin, which is hopefully post-operative change.
And they said, we removed the brain tumor. We think we got it all out. I said, well, what's next? And then they talked about the next therapy. At that moment, it struck me that I will never be that cardiovascular surgeon again that I was.
Shortly before he died, he and I had the chance to meet down at KAET TV to finish a PBS documentary we were doing. And I think that was his one regret, is that we didn't, with all of the innovative things we do, we didn't take this more seriously. You know, the NFL, I think, has done a great job at owning up to this issue of chronic traumatic encephalopathy. Young athlete, 22 years old, isn't thinking about injury to his brain. He's thinking about scoring touchdowns and intercepting passes and tackling the runner. My niece, Bridget, who's a brain trauma specialist and was the fellow at Harvard in brain injury, said, and because of a systemic inattention to radiation safety, created has been an entire generation of healthcare workers who will suffer long-term consequences of an obvious workplace hazard. Yeah, we have these methods for reducing radiation exposure, draped, we called it. Doesn't go far enough. And there's a few things, you know, reducing frame rates. Yeah, that helps. I think everything helps. Evidently, these guys don't think too much about the shield, which is, again, an incomplete barrier. But if you do use the shield, like Bill is using in this one, your nurses and techs will have lower radiation, so every little bit helps. These never made sense to me because you're protecting really the back of your head and the top of your head, and the beam is coming up this way, the scatter. So I don't understand these, and I don't think any of them have been truly shown to reduce radiation exposure. I like the egg nest. I think this is another good start, and I think it's a novel barrier system that is worth looking at, and all of these will need iteration. Zero gravity, it's a little clunky, but it's something. Rampart, there's a lot of people here who've talked to me about Rampart. And I was at Scripps this year for their meeting. Tierstein and Price were using it. And down at Emory, Bill Nicholson and Bill Lombardi did cases using Rampart. Again, in need of iteration, but an important and promising start. The system that we have employed in one of our, 15 labs is called Protego. Protego is novel in that it is basically the same material as the lead we wear, and it envelops the patient, and then we also put lead aprons here to avoid that secondary scatter, the primary source of our radiation exposure. Herms and I timed it today. It took us 4 minutes to put it on. Worth the investment. I've heard Cath Lab staff say, it slows turnaround down. Talk to me about your turnaround time many years from now when you're suffering debilitating orthopedic issues or malignancies. This is Tracy Pounds. She helped me to really get good and slick at this, and you can see what it looks like in use, but it provides protection for the entire lab. Great things that we're doing. I'm able Turn it up. To use fluoro and use some, longish cine runs to capture this.
Yeah.
And my radiation right now with the Protego system is?
You're still
Okay, so I have gotten no radiation through this system here with all the stuff we've done.
And the staff is protected,
And you know what?
right?
When
So we always think, hey, I'm not getting any, but the staff and some other, complementary systems, you don't get that.
Right, and I think that's an important thing, because you and I are going to come in here and do 1 or 2 cases today, but the staff has a full day the rest of the day. Their exposure is going to be significant. And I think it's as important that we are protecting the staff as the physicians. I mean, this is an extremely, extremely important thing. I think for far too long, we have taken for granted radiation exposure. It's invisible, it doesn't have an aroma, it doesn't have an odor. But when you hear about friends around the country, I worked for Dr. Dietrich, God rest his soul. He died of a left-sided glioblastoma. So I think it is time for us to get very serious about radiation protection.
Yeah. And by the way, once the people from the state sign off on it, you won't need lead.
And that's another thing.
And so let's talk about neck and back injuries.
Let's talk
So-
about orthopedic injury.
Yeah, one back surgery, C6 radiculopathy. So, I mean, it's a combination of orthopedics and radiation.
I want to thank Alexandra Lansky for taking this serious when I approached her about a study. She recently took the embargo off this data. This is coming out in JSCI in 2 days. We took 2 groups of patients side by side, 25 in the standard protection arms, 25 in the Protego arm. And this is what we found. Look at the radiation reduction exposure. In red, Protego at the waist, in green, control at the waist, and then Protego at the thyroid, standard protection at the thyroid. This is coming out in JSCI day after tomorrow. A dramatic reduction. 70% of these patients had 0 radiation exposure. OSHA says you can get up to 5,000 millirems a year. Extrapolating from our data, and a busy interventional cardiologist could do 400 cases a year if our data holds up and only come up to 0.67% of the allowable limit. A high-volume interventionist, if you got crazy this year and said, I want to do 1,000 cases, you'd be at less than 2% of the OSHA allowable with radiation protection at this level. So where do we go from here? I have a number of SCI members here, SCI presidents here. I'm hoping we take this on, because if we don't, no one else is. I'll step down from stop giving my homily here in just a minute. It's time for a complete overhaul in our thinking. The aspirational goal needs to be 0 radiation exposure. SCI needs to take a lead role. The Protego system, as you'll see in JSCI in 2 days, provides comprehensive protection. There are other systems that are worth looking at as well. And I put as my last bullet point, hospital administration's role. I brought my CEO here. Could you come up here a minute? Good friend and someone who I can knock on his door pretty much 24 hours a day, and I do, when I got a pebble in my shoe. Todd Laporte.
Well, thank you, David. And, obviously, what I can reinforce is that, our organization, really any organization in our position, should say, look, if we can make our environment safer for our patients and for our caregivers, we should do it. So I think it's really exciting. This is just another example of how David will just grab onto something that he knows is the right thing to do and just see it through. What's really fortunate is that we, as a community healthcare system, we actually have a very vibrant research institute. So it's wonderful now that you can interact with that research institute and we can direct attention to the kinds of matters like you're bringing to the table now, David. So I know that next week there will be an announcement from our research institute about what their findings have been. We're already excited that we're going to be the first healthcare provider in Arizona to adopt this technology, but we know that these findings are really important for everybody to see, so that they can also embrace this. And so those will be, as I understand, published in the Journal of the Society for Cardiovascular Angiography and Interventions. And we look forward to everybody feeling the same way that we do about it. I'm going to take a moment, if you don't mind, to make a couple of other just general comments, not just to this subject. David has asked me to make remarks over the years, and it struck me as I was listening to the couple of presentations previous to this, how I am one of your statistics. I had a cardiac arrest 9 years ago, and my mortality these last 9 years has enabled me to pay back and do what I think is something productive and make a positive impact on my entire community. Your life's work is what has enabled that. So I want to just say thank you for your life's work. I want to say thank you to David for being the visionary for this forum and being tireless in his personal commitment to it year after year, even remotely when we were faced with COVID. I want to say thank you to all of you for coming here, learning, and advancing research and application. And I just think it's very, very inspiring. I'll share this last part with you. Our organization made a decision where we wanted to really differentiate in terms of a cardiovascular center of excellence. And that's a long story, but I'll just say this. Our community goodwill, when they heard that this was a direction we were going, has completely rallied behind it. And last year, we raised almost, or a little over $20 million towards this concept, and we've targeted $15 million this year. So there is a lot of community goodwill and belief in what you all do, and they want to see it get done. So I'm just really excited about that. I'm excited about everything you guys accomplish here, and I want to underscore what David has said here, that we all need to embrace how to make our environment safer, especially right now where it is so competitive to attract talent. And what a wonderful way to differentiate, to say we make it, our place is the safest place. So with that, I just want to tell you, enjoy your forum. I think this underscores HonorHealth's tagline of going beyond. So thank you.